Good morning. Just going to give it about 1 minute and see if anyone else hops on, and then we'll get started. Thank you so much for being here today. All right, well, we'll go ahead and get started so we can stay on time. My name is Brianna Yoakum. I'm the Director of Accreditation for Walker, which is the Washington Alliance for Quality Recovery Residences. And today we're going to have a presentation on the Fletcher Group and learn all the things that they offer. I'm joined here by Milena Stott. She is a principal social worker and a community organizer. Milena works with housing agencies, health systems, housing operators, and Medicaid agencies to expand and finance social and health services. So building on management experience as a strategist and innovator in integrated health systems, she helps organize, design programs and reimbursement strategies that integrate services into housing. Her work supports organizations and accessing funding to support their projects. So we're really grateful to have Milena here. And this webinar is being recorded. So we'll have that as a resource if you ever want to reference back to it as well. And feel free to, if you have any questions. We have a small group today, so if you want to raise your hand or put it in the chat, Milena will definitely get to those. So with that, I'll pass it on to her.
Thanks, Bree, and good morning, everybody. Thank you for having me here. As Bree said, I work with the Fletcher Group, and I've lived in the state of Washington since 2004, and have really worked across our behavioral health agency space. So I worked in a community behavioral health agency for about 12 years, and within that role, I worked with the crisis system and the criminal and legal systems to get people access to housing and services when they were in crisis. I also ran a residential treatment facility and medication for opioid use disorder program. So I know a little bit about our continuum of care, and I've been with the Fletcher Group since 2019. And the reason I joined the Fletcher Group is because of their focus, which was on recovery housing. As a licensed social worker and drug and alcohol counselor, I have worked both in programs and with individuals who need services, and oftentimes housing is a critical factor in somebody's recovery. And so as a treatment provider, when I was providing services to people who didn't have housing or had unstable housing, I knew how disruptive that was to their care. And so I really like the mission of the Fletcher Group, which really looks at aligning those social things that people need from their communities with the clinical things that people need from the health system, and how do we make those all kind of work together. So my presentation today is focused on the structure of the Fletcher Group, and towards the end I get into the development work that we do around how we help people develop programs and services. But initially I kind of cover like the methodology and the backing of that. So with that, I'm going to share my screen, which has my presentation. Can everybody see it okay? Since we are a small group today, please do raise your hand and stop me. I hope that this is more discussion oriented, and if I get to a topic that is of interest to you or you have questions about, I definitely want to be able to stop and have a discussion if we'd like. So before I begin, are there any questions? And please feel free to introduce yourself, your organization in the chat. Maybe let me know what part of the state you're from, how big your organization is, and maybe a little bit about you. All right. So the Fletcher Group is a rural center of excellence in substance use recovery. And we really use an ecosystems framework to reflect our work. And today I'm going to talk to you about that ecosystem framework. It's really a fancy way of saying that people live in an environment, and that environment affects, how they live and what they do. And then what we do, which is really around our technical assistance and toolkits, how we engage partners, how we develop these different programs and services, how we can help you implement new projects, and then some work that we're doing on measurement and how that sustains the work of recovery housing. We'll talk about how recovery housing fits in that recovery ecosystem, and then really kind of end with a discussion on, the future of recovery housing and how do we elevate and sustain this great work that is happening. While these websites are currently being reviewed, you may find that there's information that is not available on them. But having said that, HRSA funds 3 rural recovery centers, and we are one of them. But the other 2 are the University of Vermont, and they have a focus on medications for opioid use disorder and treatment services. And then New York has a focus on prevention, and we are recovery. So you've got kind of the continuum. What you'll find in the clearinghouse that is available is research and toolkits that are catered to addressing barriers or developing programs in each of these areas. So what is the Recovery Center of Excellence, and really what is the nature of our work? So since we've been in operation since 2019, we've really been focused on rural communities. This is a rural HRSA grant. And our role is seen oftentimes as a community catalyst. So we engage individuals, organizations, or communities through a boots on the ground approach. So that might mean attending meetings, organizing meetings, meeting with individuals that have ideas, that want to move some work forward. And we provide them the backbone support and sometimes the encouragement and the knowledge to be able to drive their vision forward. This is hard work and the system's complicated. And so having that kind of person who's helping you in the background, who knows the system, who can pull in different resources from across our team is helpful for individuals in moving the work forward, because it takes time to learn things. So you can learn, you can build, or you can partner. And so we partner. We also drive best practice and innovation. And that is really, we're doing research and we're getting access to information and we're disseminating that information through emails, through webinars, through toolkits. We also offer training and technical assistance. So we have different subject matter experts in the field of, criminal justice or public health, medications. And so those individuals will meet with recovery homes that are trying to address one of those things and really provide one-on-one technical assistance, or sometimes meet as a group and provide training. We have a learning management system that also is available to folks for training. And then last but not least, research and evaluation. Because we want to make sure what we're doing is working, we study that. We ask for feedback, we collect information, and we'll talk about at the end some of the research and evaluation that we have done so far. All right, I'm just going to check the chat real quick, see who is with us, say hello. See hello, Jody and Eric. And Arnell, I hope I'm saying everybody's name correctly. Welcome, and Darcy, welcome everybody. We have behavioral health administrator, Kina, Michelle. All right, well, thank you everybody for coming. I look forward to the discussion component and your questions as they come up. All right, so the ecological model. So this is kind of like the ecological model, and there's different levels of influence, right? But we do this from the framework of the individual. So related to practices that we do with individuals. We promoted efforts around smart recovery and contingency management as best practices for services to integrate into recovery housing. We developed a satisfaction measure. For those of you who know about the Therapeutic Alliance as being a key factor in helping people move through their recovery, that addresses that. We've done surveys to understand the perspective of people in recovery. All right. And then related to the interpersonal, we look at ethical considerations and therapeutic alliance, and we've developed a measure around that. And we know that individuals interact within, a recovery home. And so really we're trying to study the impact of those interactions on recovery. Then there is institutional and organizational work. And we've done a lot of work on, outcomes and the training needs of recovery housing operators. We've done employment coaching and training implementation programs. We do peer support and employment evaluation services, and really all with the focus of how organizations and institutions, can help support recovery. At the community level, we worked with messaging to reduce stigma and increase support for recovery housing. We developed a recovery ecosystem index that allows folks to look at what resources are in the community that support recovery efforts. And if they're not there, how do you address the gaps? We are working with physicians around barriers to serving individuals who have a substance use disorder. And then we did a national landscape assessment of, what is going on across the US with recovery housing. And then last but not least, we all know that the policy environment very heavily influences our work. And so with that, we work really closely around policies and procedures with the criminal legal system and how to support individuals in recovery. We review state-by-state legislation. We're doing some work around alternative payment and value-based models, which we'll talk a little bit about as well, related to our economic calculator. We've developed a taxonomy of the key characteristics that are in place for states that have been successful in advancing recovery housing. And yes, Washington is one of them. And then, we work really closely with ASAM and single state agencies on what they're doing, because that's where a lot of the funding and criteria for access to funding come from for recovery housing. And so as you can see, we're kind of targeting all levels because there's a relationship across all levels. And the idea is that every level is looking for policies and programs that, support and advance recovery. All right. So all of that translates into tools. So we study things and then we use that knowledge to bring tools to the community. And so we have project management support. Our team is trained in project management, and we offer project management support to large projects. We have our toolkits. We have webinars, and we actually have a resource catalog that kind of tells you all these things. And all of these webinars and toolkits are built based upon community feedback around things that they're having trouble with in their communities. And then we do our TA and training, our research and dissemination, and we also organize learning collaboratives. What you see here is a little advertisement for our learning management system. Now, Walker does a really nice job of putting together webinars and bringing topics for everybody and making those available, but not all states have that available. And so this learning management system provides access to those learnings. So since we started in 2019, we're active in 38 states. We've done 425 trainings. We've assisted 57 housing projects. And we have, thousands of TA encounters with individuals wondering about recovery housing or recovery support services. So why do we do what we do? Since I'm a big systems person, I love systems. I respect that not everybody feels that way. Systems are hard and complicated, and I find that challenging, and so that's why I like it. But sometimes that's actually limiting. It is complicated. It's hard to know where to find information, how to find information. People aren't talking, they're not coordinating, we're not aligning all of the things that people need for their recovery. The resources are limited. There's a lack of different services or payment for those services, right? Motivation for change or isolation, can be challenging to manage. Stigma and confidentiality concerns are abundant. And so we're there to support people through those conversations. Because these are big needs that we have in our community, and the resource or workforce isn't always there. And so we empathize with the struggle of organizations who are trying to make things work and finding qualified staff to be able to do that. So when we sit alongside folks, our hopes is to minimize their burden by doing the things that we can so that they don't have to. So when we're working within our work, we consider all of the factors that influence health, right? So I showed you the ecological model. This is more kind of focused at the individual level. Somebody's genetic makeup, their age, their sex, their genetics, those are the things that they're born with, right? And then their lifestyle influences how those things turn out. Their social and community networks also influence how those things turn out. The living and working conditions, the type of job that we have, access to education, access to housing and health services, water and sanitation, those are all things that influence the development of an individual. And then, of course, the general economy, culture, and environmental conditions, right? These are all things that impact our health. This is a model that two researchers put together on the socioeconomic conditions that impact health, right? And so that's kind of the basis for the recovery ecosystem framework, is that the person's in the environment, and that individual are constantly interacting in a way that influences their health and their opportunities. So here's kind of getting into some examples, right? So factors that influence substance use and recovery. I call these risk factors and protective factors. So protective factors can be physical, social, or mental health, right? When you live in a safe home and neighborhood, you're not exposed to certain things like trauma, right? When you have physical safety and you feel like you're included, that addresses your needs for attachment. The quality of education and school setting, right? That influences your opportunity for employment. Access to healthcare. If you have a health issue that makes it so that you can't work or go to school, but you can't get help for that healthcare issue, you're going to fall behind, right? Family and caregiver support, education and employment opportunities, food, community, culture. Those are all things that nurture an individual, and those are all things that we try to bring to a recovery housing environment, right? And that's kind of our goal within the spaces that we create for people and how we help them connect with services and community. And of course, the opposite of that, these are the things that make it more likely. For those of you who know about adverse childhood experiences, people who have high scores have a significantly higher percentage of risk for substance use. So things like poverty, economic stress, right? Social stress, economic stress leads to social stress. Those are risk factors. Conflict and war, homelessness, being excluded or lacking resources or support, when things come up, you need those resources or support to address them. If you don't, you can't address them, and you kind of go into this vicious cycle. Limited opportunity for community engagement or pro-social activities or even employment, right? Mental health, trauma, or adverse experiences. So those are all risk factors. And in our work, we look to reduce those. That we know that if we reduce the risk factors, we reduce the development of the disease. So the cycle of substance use disorders. This is from a World Drug Report, United Nations publication. It talks about the cycle of substance use disorders. Now, you can start anywhere in this cycle, right? But the idea is that these things build on each other. That once, you might just drink casually and you lose your job, or you have a limited job, so your drinking increases, and then all of a sudden it's significant and you're missing work, right? And that can lead to conflict in the home or loss of employment, which leads to poverty, right? Which leads to more substance use for coping. And it's this kind of cycle of hopelessness. But substance use impacts employment, and then that impacts housing. And so within our model, we're looking at how all of those factors interact, because you can't just tell somebody to stop using substances. Sometimes they need training and education and access to support, right? To be able to get an income and get housing. So the other thing that we look at in our work is what ASAM is doing. So the American Society of Addiction Medicine puts out a publication. This is their 4th edition that just came out. And this publication is basically a guide on how you assess for substance use disorders, and then how you define the placement or the services that people need, the level of care that they need. So the beautiful thing about the 4th edition is that it incorporates recovery housing and recovery support services into the continuum of care, in addition to some other changes that they've made. And 45 state Medicaid programs use the ASAM criteria to place people in substance use treatment services and programs. And health plans reached an agreement with ASAM around the authorization of the criteria, for payment for services. So basically they reached alignment, and they said that when these things are true within an individual's assessment based on the criteria, we agree that that's the type of service that they need and that we'll pay for it. So that's significant, right? This is kind of the manual, so to speak, that tells you how to deliver care for folks who have a substance use disorder. So within that manual, the dimensions of care align the social and medical needs in the placement consideration. So on one side of my screen, you see dimensions 1, 2, and 3. Dimension 1 is intoxication, withdrawal, and addiction medications, right? So you're looking at the risk of somebody medically when they are using or withdrawing from substances. Dimension 2 is you're looking at their medical conditions and how their medical conditions affect their use, right? So if somebody has had delirium tremors or has seizures and is using alcohol and benzodiazepines, for example, that's a medical condition that impacts the withdrawal process, right? So a very medical thing. And then dimension 3 is psychiatric and cognitive, right? They're looking at, in addition to the physical health, they're looking at the mental health, and how does the mental health affect the withdrawal process. So when somebody's getting admitted into a withdrawal management or a medically based program, right, this is kind of the meat of the assessment. What are their medical needs and their medical risks at the time of withdrawal? Somebody who's on methamphetamine and psychotic, right? That's a intoxication and perhaps a psychiatric, mental health consideration. So those are the very medical components of ASAM. The social components of ASAM look at risk, right? Substance use related risk. So what has their history of use been like? How risky is their use? How risky are their behaviors associated with the use? And how do you create the environment that supports the individual in managing those risks, right? So the more risks they have, the greater they have for support in a home environment, right? Because they need that supervision and that added support to reduce their risk. Number 5 is the recovery environment interactions. How are they able to function within the current environment? There's a lot of debate around secure withdrawal management, but that's a big one for folks who can't maintain in their environment and are a risk to themselves if they leave. So how can the current environment support them, create a sense of safety? And are they willing and able to participate in that process? And then number 6 is person-centered considerations, right? So what are people's preferences, their barriers to care, their need for motivational enhancement, right? So this is where kind of those risk reduction elements come into play here. Is that, the motivational enhancement can help address the risks and turn that into a recovery pathway. But the idea here is that if you don't address preferences and if you don't address barriers, you're unlikely to engage the person in a meaningful way. And so what ASAM is saying that, these medical risks may be low. However, there may be some social considerations that influence the intensity of support that they need outside of a medical setting. All right, and this here is kind of it's their diagram on the levels of care, right? And the idea is that you're moving through this continuum. And the idea is that you're also stepping down. Now, the practice does not reflect the best practice, right? Because a lot of this it's not fluid, it's based on capacity, right? People come in and out of these different levels, but this is kind of a guide from an assessment standpoint. So your higher risk people are going to be at your, inpatient facility. That's where you're going to see dimensions 1, 2, and 3, those medical things, those medical needs, they're going to be super high, right? They're going to need a nurse, they're going to need a doctor. Level 3, you're stepping down into residential, but there are medically managed residential where there's on-call doctors and nurses 24/7. Then you're moving into level 2, which is your traditional community behavioral health agency outpatient, as well as level 1. And then you add recovery residents in here. And you can enter into a recovery residence level of care, or you can step down. But you can also be in a recovery residence and receiving level 1 and level 2 services. And many recovery residences are developing models for level 1 and level 2 services. In addition to the traditional recovery residence life skills and employment support services that we offer. All right, this is probably review for many of you, but in case it's not, I think I saw a couple of folks on here who are not in the recovery health space. In partnership with NAR, which is the National Alliance for Recovery Residences, ASAM and NAR transitioned the 4 NAR levels into this lettered nomenclature, PMSC. For peer run is level 1, monitored is level 2, supervised is level 3, and clinical is level 4. And here you can kind of see the spectrum of services and what gets added when you go into those higher levels of care. All right. So what is a recovery ecosystem? We've already started to talk a little bit about that, but now we're going to kind of move into how it works. I don't know if I can play this or if I'm sharing sound. I might need some tech support here on the sound sharing. But we're going to try. Can you hear it?
Oh,
Mental health and substance
yep.
disorders affect
Hear it.
millions of people from all walks of life in rural and urban communities. These illnesses are common, recurrent, and often very serious. Yet they are treatable, and many people do recover. Unfortunately, for far too long, substance use disorder has been viewed as a moral failing. It has been criminalized, leading to discrimination, mass incarceration, and a complex web of barriers preventing access to recovery support services such as treatment, housing, and employment. Because of these barriers, individuals have been prevented from rebuilding their lives, with devastating impacts on individuals, families, and rural communities across the nation. Yet, there is an evidence-based solution to turn this trend around. In all communities, and particularly in rural America, research has shown that an important factor in successful recovery is a recovery ecosystem. A recovery ecosystem creates the environment that individuals and families need. It provides peer and social support, education and training opportunities, employment opportunities, transportation supports, childcare supports, leisure and recreational opportunities, housing, and access to healthcare and mental health services. A recovery ecosystem surrounds individuals with the ability to remove barriers, pursue meaningful employment, and maintain recovery transitioning to a productive and positive quality of life, engaging with family and community for a lifetime. Research over many decades has shown that substance use disorders require much more than a 30-day hospital stay to heal the brain, body, and spirit. In rural communities, developing a recovery ecosystem supports individuals and families by providing a range of evidence-based methods for dealing with the complex issue of substance use disorders. They also help the wider community by reinvigorating economies with a capable and willing workforce, and ultimately bringing people together in lives fully lived, which reverberates benefits across entire communities. For more information about how your community can develop a strong recovery ecosystem, visit the Fletcher Group online.
All right. So in a recovery ecosystem, it starts with community, right? So we talked about our role as being community catalysts, and a lot of the work that we do is bring stakeholders together to have the conversations that they need to move forward the vision of the project that they have. Sometimes the focus of that conversation, because there's a relationship between the criminal legal system and substance use, we work very closely with that system on diversion in lieu of punishment. So a lot of efforts like the LEAD program, this state has the Recovery Navigator program that's attached to some of that work. But it's all about, helping people move from this system to the community. We also work with recovery housing to engage in partnerships with treatment providers. Walker has the Community Behavioral Health Agency Partnership Toolkit, which we worked together on. But sometimes that also means working with a treatment provider to build recovery housing. We have some behavioral health agencies in the state of Washington who have begun to do that, and that's super exciting. Then a big component that we help the medical system recognize is the support or the social elements of recovery. And how do you bring that together with treatment to support the treatment through peer support services? Then we look at employment, and that once people are stable in their treatment and stable in their housing, they're really able to advance and focus on their training and employment skills. And then the last thing that we do is we study recovery homes and their outcomes to show proof of the programs so that we can continue to basically develop a strong foundation of support because we know that the service works. So who participates in a recovery ecosystem? This can vary from community to community. It can be small, it can be big. But some examples are local and state officials. They become, county commissioners and local officials become really important in advancing both from a funding and political aspect, as well as like a social and NIMBY aspect, right? Hospital and health systems, they also have a role in this. People with substance use disorders often show up to hospital and health systems, and they can be a point of entry. Medical providers and behavioral health organizations, community health centers and community-based organizations and public health. The criminal legal system, the faith-based community, public safety and first response. Transportation is a huge one and becomes actually a critical one to be able to transport people to health services and employment. Housing operators and providers, human services professionals, and educational institutions. I always like to ask here, is there anybody I left out? Feel free to chat it in the box if you don't want to say it. Okay. So how does a recovery ecosystem build recovery capital? I know some of you guys use the recovery capital scale. But the idea is that, and you see here recovery housing as the foundation of that, right? But the idea here is that people come into recovery housing through the criminal justice system, through treatment providers, through counselors, community support, or they come self-directed. When they enter recovery housing, they receive case management support and peer support. They get access to stable housing, education support. The case management is intended to connect them to physical and mental health services, life skills, and employment support. And the idea is that they're getting these things while they're in recovery housing, the social and medical components, right? So that when they leave recovery housing, they can leave with stable employment, access to transportation, housing, and social support. Peers as part of the ecosystem. Yes, peers are very much there and they're here under support. So peer support and mentorship builds relationships while instilling a camaraderie, a strong work ethic, and full accountability. So we have peer support and mentorship in that part of the ecosystem, and then peer providers can be employed anywhere else within these organizations here. Thank you for the question. All right, so that's a lot about the why and the context and the system. So how do we work with people when we begin to work with them? Well, the first things first. So we have two limitations in our work with people. So we're funded by two different grants. One is the HRSA grant. And within that grant, if you are a rural provider, we are able to provide technical assistance and, catered support. If you are an urban provider, you are able to access our tools and a one-time TA and, some email correspondence. The other grant that we recently received is a HUD grant. So we are now funded by HUD to provide technical assistance to anybody receiving HUD funding. So there's, other than receiving HUD funding, the other criteria is working towards, SUD and recovery support programs, because that's our expertise. So those are the two criteria in which, you can get a free consultation and training Of course, the toolkits and webinars are available to anyone and everybody. And I make myself available as well to answer questions, especially to, colleagues here in Washington. So having said that, that's the limitation to the free services that we provide. We do have other contracts with providers across the US to do some of these things. So our process really starts with a needs assessment. We have what we call it an onboarding client tool. And really in this tool, we're assessing what stage of the project you are in, which is, kind of the next box there. And what your barriers and needs are, right? Like, where are you in your process? Are there things that you've bumped up against that we can support you with? And so once we define, that project stage that you're in, we then develop a work plan where we look at the technical assistance and coaching that we can provide around capacity building. We look at our products and tools that we have available that align with, the questions or goals that you're trying to achieve. In some cases, we've established self-directed and group learning. We use our learning management system and our webinars, and really we're kind of managing the knowledge that you have or need to advance your project. I've been doing this work a long time, and we don't know what we don't know. And despite how well you plan, stuff comes up. It just does. And so we use the experience of others and our process for walking alongside them, as well as the research that we do to look at what are the common things that people struggle with or that they need to know, and really then we develop those products. And then at the end of the engagement, right? So for folks who are in the sustainability phase of their work, we're really working on, data analysis and reporting and management so that we can track the success of that work and then use that data to get more money for the work. So that's kind of our process in a nutshell. And I think I saw a question. Does receiving HUD funding include? Yes. So if the main thing with the HUD TA is that the person receiving, the entity receiving the HUD funding has to request the TA, so that the initiation happens from the client. So our process is to basically do a meet and greet, understand what your needs are, and the extent that we can support them, make some suggestions about what you might write when you outreach for support. But yes, people receiving continuum of care funding, that is HUD funding, and it is eligible for our support.
Okay. Can I add a follow-up to that question to that? So
yeah.
I work for Lewis County and will be helping them revise their 5-year homelessness plan. And I assume that some component of helping people get into recovery housing might be part of that. Is your technical assistance a one-time only thing? Or if they ask for technical assistance, say now, would they be allowed to ask again in 2 or 3 years if they wanted to?
Yeah, so we're funded through 27. And yeah, so you're able to ask as much as possible. We work with the HUD office in DC, and they very much want to see recovery housing programs be successful. There was a pilot program that was funded. Washington is not a recipient of those dollars, unfortunately. I guess we do too well to receive them, which is both, I guess, a good and bad thing. But this recovery housing program lies under the CDBG block grant kind of office, and they're looking at the state of permanency for that program. And so so the TA is really intended to make a lot of this work. So we're also new, right? This is all within the last 3 months, and we all know what is happening with the job shifts, in DC and folks leaving different departments. So, but we have a very responsive group of individuals that we're working with. And so as long as we know TA requests are being made, once they're made, we're able to kind of like follow up and track things down on the back end. So that's what I'll say to that. But yes, absolutely, they can request the TA. It is not one and done. We have to propose a work plan to HUD and allocate hours to it.
Thank you.
Yeah, you're welcome. Okay. So our client onboarding tool, right? So when we onboard a client, what we're looking at is what are your goals? For those of you who work with clients directly or are clinicians, right? We're doing the same thing. You know, a doctor's kind of doing the same thing when we go in to our visit. So what are your goals? Where are you at in the process, right? What are the things, the barriers that you've encountered? What are some of your notable milestones? Where are you finding yourself getting stuck and what support do you need? And then we look at like what tools that we offer. So that's in a nutshell what the client onboarding process is. Sometimes, by the way, it may actually involve like an environmental scan of your community. It might involve reading like a recent report, right? Because we want additional context to the experience. But this is what the conversational part of onboarding looks like. So in our pre-development work, we're doing a lot of planning. So we're looking at asset and stakeholder mapping. Every community is different. There is not a cookie cutter template for this. With asset and in stakeholder mapping, you know, or environmental scanning, we're looking at like, what are the needs of the population and the alignment of the program? So people need this, but does your program address that? What are the funding opportunities that are available for your program? And then we kind of look at it from like a SWOT analysis, strengths, weaknesses, opportunities, threats, right? We're considering all of the different elements, but really in a SWOT analysis, we're looking at two things. Is there leadership and political support? Because those are critical success factors. Without a leader, you're not going to advance things. And then the political support, you know, can make or break a project. And sometimes the leader can shift the political, you know, conversation, but not always. So we're kind of evaluating those things. And it may be if there's not support, where we're starting is with not in my backyard strategies, where we're doing outreach and education and stigma reduction work, right? But we know that without those things, the project is unlikely to succeed. We've literally had community protesters come in and shut down, you know, projects in Oregon when they were getting, you know, literally free money from foundations. We look at community engagement. To what extent is the community engaged? What's the temperature of the community perception? We look at the project concept or design, and then we consider feasibility and leadership. Somebody has to own the project. There's lots of people that want things, but sometimes no one's willing to step up and say, I'm going to be the project owner. I'm going to be the sponsor. It's going to be my organization that takes in the funding. Then we're doing pre-development preparation work, right? You can't write a plan without a site. Oftentimes people have these beautiful programs, these beautiful staffing models, but they have no place to put it. When we look at site selection, we are considering things like, are you leasing? That's a pretty easy startup, right? What's the size of, you know, is it a small recovery house and you're leasing a small recovery house, right? Versus a larger recovery house, and maybe you need some rehabilitation work to be able to meet the certification requirements. So we're looking at all those things. Are you going to acquire, you know, acquiring a new construction as well as leasing, you know, it's different budgets that you're going to build. It's different fund sources that you're going to have to explore. You know, if you're going to acquire a building, you might apply to the Department of Commerce for some funding, but your services, you know, funding is going to come from the HCA. Same with new construction. With new constructions, not only are you going to have to buy the, you know, building, you're going to have to build the building. You're going to have to go through construction review. You're going to be subject to feasibility studies and environmental surveys and zoning. We have an urban planner on the team who, you know, manages a lot of that work. Then you're looking at business planning and financing strategies. Once you have an idea of your cost, you're going to have to kind of figure out, you know, how you're going to pay for those things. That may involve things like researching things that are available like rental assistance. The state of Washington is blessed to have rental assistance for individuals. So, you know, in terms of a business plan, you'd have income coming into the program for that. Looking at regulatory approvals, and then really moving into fundraising and grant writing. I include board engagement here because I have been a part of so many projects where the board shut it down because they weren't engaged, and things changed. And so, you know, board engagement is a key thing. And these are all, you know, things that we're assessing, you know, in the project. I have a project right now where the board member had to become the president because of some transitions, because the president had to staff the recovery house. And the board member owns the house and is now the president, and there's all these conflicts, right, that are happening. So those are the conversations that we have with communities. During the development phase, we're looking at final design and construction, permitting and final approvals. You're selecting the contractor. And by the way, if you're leasing, none of this has to happen. So you kind of skip this phase. You're doing the construction and the financing and the management. This is where people get hung up, right? Like in construction, there's a process called change orders. If you don't have a change order for everything that you want to change, you're going to find you're off budget pretty quickly. Change orders are also required because if you are, you know, under a HUD contract or other government contract with strict spending categories and limits, you know, you have to be able to provide the justification for those changes. So, you know, so we work with folks on that project management side and managing those conversations. The other thing that happens during this phase is the community partnerships and program development. You know, you're really looking at what you can deliver versus what you need a partner for. Remember that ecosystem concept and all those things that people need. If you don't have it, a partner can provide it, and a good partner is going to help you have good outcomes. That's also where you're going to get referrals, right? So in addition to having partners that provide services, you're going to have partners that provide referrals, you know, so those are your referral channels. And then you're looking at the program structure and the funding that supports that structure. And then you're starting to think about recruitment and hiring. You got to build those job descriptions. And we know workforce is a challenge. And so recruitment, I think, starts right away, especially recruitment of your leadership. So implementation is really about finalizing and operationalizing the project. I think that implementation is the forever phase, honestly, because implementation, if it includes quality, it includes process improvement, and it means you're just kind of always implementing improvements. But for the purposes of this stage, we're talking about inspections and occupancy certificates, really moving folks in. Continuing the hiring and training, continuing the marketing and the referral channels. In addition to the hiring and training, now you're also doing staff onboarding and training. You're looking at property management and service contracts, the process of how you move residents in, finances and compliance, and long-term operations. I actually don't have policies and procedures on that list, and I'm going to add it, but policies and procedures is another huge component of implementation. In the sustainability phase, you're looking at staff training and cross-training. Staff training and staff development, you know, the organizations that are most successful, that is just always a part of their work. Because when people leave, they leave big holes, because we often don't have a lot of resource to have abundant staffing. In sustainability, we're also modifying and improving operations. We're expanding. We're developing new referral networks. We're staying in touch with our alumni. You know, the folks that show proof of our program, and we can engage as part of community towards our recovery initiatives. And then you're doing operation success planning and support. We like to call this operator resiliency. We know that in the startup phase, like people are willing to give like blood, sweat, and tears for like the first 5 years, and after that, that founder's motivation may diminish a little bit. And so, you know, how do we make sure that the work is sustainable, both within the organization and the community? And then the last component is measurement. You know, how do you identify the key performance indicators and program measures? Those are the things that get you funding. In a world where funding is competitive, data is our friend because it shows that you're better than others. So selecting those measures and performance indicators are something that we cheerlead quite a bit. We also help people develop a process for gathering information, and we have a partnership with Walker to do that for the network. So excited to share about that on a different day. We can help select tools for gathering information. We can help you develop a process for managing the data, and we can help you with data analysis as well. Our biggest project to date that we've kind of taken through all of those phases is our ROAR model, which stands for Recovery, Hope, Opportunity, and Resiliency. It's a successful Recovery Kentucky program, which is where the Fletcher Group started, was with 1,800 recovery beds in the state of Kentucky, a partnership between HUD and criminal justice. And so with that project, it was a long project. It was a 4-year project. COVID happened in the middle of that, so may have affected the timeline a bit. But we started by mapping the community resources to understand the available support. We engaged the community champions to lead and advocate for the recovery efforts. We identified the gaps in 3 areas: treatments, health-related social needs, and coordination between providers, recovery housing, and the criminal legal system, as well as other resources. We connected with fair chance employers to create job opportunities. We partnered with education and workforce programs to support recovery to work initiatives. We assessed transportation and needs resources to improve access to care and employment. We united stakeholders with a shared goal, and we closed the gap through the ROAR model. Now, this is not the size model that every community needs. But this was our largest project to date. The Recovery Kentucky centers average 100 beds each. All right, before I move into the research component, are there any questions about everything I've discussed so far?
Milena, there was a question in the chat. I'm not sure if you answered it. Okay, you must have answered it. Never mind.
Okay.
Oh,
All
looks
right.
like you got someone with their hand up. Eric.
Yeah, I have some other questions, and
Yeah,
forgive me
please.
if I end up wasting everybody's time. But so you mentioned earlier that that because of the criteria, the ASAM criteria, that now there is beginning to be a Medicaid tie-in for recovery houses. Have you worked with any states like Washington that have Medicaid waivers in which they're using Medicaid funds for housing? So I'm thinking in Washington about foundational community supports or Apple Health and Homes. Like, do you have any connections to those?
Oh yeah, so Medicaid waivers I love Medicaid waivers. I've been involved in Washington's Medicaid waiver for a long time, and the Community Behavioral Health Agency Partnership Toolkit is based on integrating recovery housing and foundational community supports. We have some houses in the network, one that I'm currently working with, that are delivering those services and are certified through Medicaid to deliver those services. So that's an income stream. There are states that are our state uses the substance abuse block grant for rental assistance for recovery housing. So non-Medicaid funding. There are some states that allow for billing of peer services in recovery housing. So there's a few different initiatives. Every state is different, but I will actually cover in our single state agency survey that our research did research team did, some of our findings related to how Medicaid and single state agencies are funding recovery housing and their perceptions of it. But in Michigan, I'm working with a house that receives Medicaid funding, and they pay. The criteria is that folks have to receive an assessment, they have to be enrolled in outpatient services, and then the recovery house has to deliver a certain number of peer services.
Okay.
But yeah, it's actually more common to use non-Medicaid funds than it is the waiver.
Okay. Yeah, I had like actually I had 3 different blocks of people that I thought might be interested in your services, and that was one of them because we had a behavioral health provider that was like looking at foundational community supports because they were sick and tired of trying to help treat SUD patients who are homeless under a bridge that's like just not conducive to treatment, and they wanted to find a way to try to get them housed, but it never came together. So separately, the drug court, Lewis County's drug court, I've like worked with them before. Do you have any experience working with programs that help people that are either progressing through or exiting out of those types of programs?
Oh yeah, I used to work with the King County Criminal Justice Initiatives, reentry, drug court, mental health court, diversion. I mean, our Washington's a pretty progressive state, and we have abundant programs that do that. But yeah, I mean, we work with the courts all the time. We have a director of criminal justice on our team who specializes in those conversations.
Okay. And then last one, I promise.
Yeah, no worries.
A third entity that might be interested. What about entities that run inpatient SUD treatment facilities? Lewis County has an involuntary SUD inpatient treatment facility, right? Like a place where you can get committed for severe SUD disorders. I don't know. They have, exit, exit planning as part of their facility, but I don't know there's a lot of opportunity to cite people if they happen to be local. Do you have any experience in like working on step down facilities for people coming out of such things?
Oh yeah, I used to run a residential treatment facility. Those facilities have to build partnerships with recovery housing. Washington State has a requirement actually that anyone in a residential treatment facility has to refer people to recovery housing that is certified. And then they can access the funding for the rental assistance. They can access the FCS services for the housing case management transition support. And the MCOs are required to work with people who are inpatient into stepping down in the community. So there's a lot of regulatory components, what is often, and payment components. What is often missing is the coordination and the partnership.
Okay, sounds good. Thank you. I'm glad I'm here. Learned about all these things I could offer to various players that I know of.
Yeah, no, you are most welcome. Again, I've been doing this work in Washington for 20 years, so it's like I know it well, and I travel across the state and I hear from a lot of folks. So yeah, I've also done like a landscape assessment of Washington specifically, so I know a little bit more about this state than others. All right, so I've talked a lot about NIMBY, right? This whole thing around political support and leadership. It's really important that you address NIMBY and that you control the community conversation and that you address the stigma. Because you're gonna have folks who really diminish your project if you don't. So we did a study and we wanted to understand if facts and personal recovery stories reduce stigma. We wanted to understand and address recovery house NIMBY across rural communities, and then the impact of storytelling on support for recovery housing. So what we found in this study is that personal recovery stories can reduce social SUD stigma and increase support for recovery housing. Personal recovery stories to reduce stigma and increase support for recovery housing by improving perceptions of people and increasing their beliefs about the effectiveness of recovery housing. And then people in rural areas have unique concerns related to the expansion of SUD services and recovery housing. So those were kind of our three takeaways, and we really use that information to influence our messaging, right? That really it's about increasing beliefs about the effectiveness of recovery housing is an important focus in addition to storytelling. And we have 2 research publications that were accepted related to this survey, and they're listed here. And I can send a copy of the slides, by the way, to Bree for dissemination after this. We've also done a cost benefit analysis of SUD programs. So we did a literature review, and the literature is kind of sparse and limited. We've looked at different treatment methods and different types of treatments. But most of these studies are short-term individual outcomes. They focus on a single program or system, and the methodologies vary. And what we know is you can't place things, SUD recovery is a long-term process, and it doesn't involve just one person or one system. We know that people with substance use disorder, they touch many systems, and that systems working together is part of the key success factor. So some of the factors that we considered in our research was the location, the size of the program, the cost of the program, and the success rate. We prioritize costs and benefits that are measurable and consistent so that we could compare apples to apples. We looked at reduced health costs through decreased emergency care and hospitalizations, or lower criminal justice expenses, or increased productivity in workforce participation, or improved health outcomes. So benefits of SUD recovery: reduced healthcare costs, lower criminal justice expenses, increased workforce participation, improved health outcomes. So those are the benefits. The measured costs were the operational expenses of running those programs. Now, many recovery housing providers participated in our economic calculator study. If there's any of you here, thank you for your participation. But we did do this in Washington, and we want to look at cost against outcome, right? And so what we learned about the recovery process is that it's not a single event, that there are key recovery indicators, and they take 2 to 5 years to align, and that to accurately model this time lag in recovery benefits, our health economist created an algorithm to be able to measure that. And so here are the economic impact of SUD programs. So the variables are listed here: the operating costs, capital costs, what it takes to, so how much it costs to operate it, how much it costs to develop it, the success rate, the total benefits, total costs, net benefits, return on investment. So what you see here is that the cost of a residential clinical program is high, right? The outcome is not better than the others, and the return on investment is low. You get the highest return on investment on a recovery house, partially because the costs are low and the success rate is up to par. The recovery campus, the success rate is higher because it includes permanent housing, and you're, keeping track of those individuals longer, they're receiving support longer. So the tool is available freely to all programs. Since it launched in 23, we've had 274 organizations participate in it. We've done it with 8 states, and the tool is published. So it has been peer reviewed by other health economists, and they put their stamp of approval on Dr. Ashworth's work. And so early in her career, this amazing young lady published this tool, and it's revolutionizing the way that we talk about, cost and outcome in the value-based world.
Yeah. Milena, Arnell, did you have a question? I seen your hand up.
Yeah, so how did you measure success rate on the previous table?
Yeah, so I can tell you how we measure success rate generally. So we
Yeah.
use the initiation, engagement, treatment, and retention measures that are like, are you familiar with HEDIS?
No.
So they have quality measures that are developed. Some are proprietary, and then like HRSA has the UDS, but they use claims data to look at when a person initiated treatment, the number of encounters that they had, and the duration that they participated in the program. But I can get an exact definition of success rate from Dr. Ashworth as it relates to this particular.
Okay, but it's looking at like the decrease in engagement rates with
So
in terms of like to be able to sustain the recovery.
So we're looking at reduction in use,
Yep.
engagement in health services, and then reduction in clinical scores, right? Like the
Okay.
PHQ-9 or the GAD-7. So you've got one that's an individual success rate, right? Is the individual, like, are their symptoms decreasing? And then engagement in treatment is a process measure, right? That we know that once people engage in treatment. Now, the other thing about SUD recovery programs and recovery housing in particular is they do urine tox screens. And so, and it is, while, supporting people through a recurrence is a common practice, there are some people who cannot be supported through that recurrence or choose to leave.
Sure.
And so that's another factor around success rate is, retention in program through participation of program requirements.
Right. So there's a tangible methodology rather than just going, oh, they've got this many, clean years or whatever. Yeah.
Yeah.
Okay. Thank you.
Yeah, you're welcome. All right. So going back to that question around Medicaid and Medicaid waivers. So in 21, we basically did a survey of all the single state agencies, and they oversee all of the publicly funded drug and alcohol treatment. There is a National Association of State Alcohol and Drug Abuse Directors, NASADAD, which basically has the name of every director of every state agency who works on substance use work. And so we disseminated the research through that, or the survey through them. And basically our goal was to understand state level support and policies for recovery housing. And why that matters? Well, if state agencies support it, they can fund it. In a nutshell, they control the Medicaid budget. And the survey asked 24 core questions, to look at the vision and planning around recovery housing, legislation, community support, awareness of its, need, quality improvement activities, and the level of prioritization. We surveyed all 50 states plus Washington, D.C. between October and December of 2021. 48 out of the 51 states responded, so we had a 94% response rate, which is fantastic. 60% are classified as rural, with half or more counties considered as rural by HRSA. So basically 98% of all of the states see recovery housing as an integral service. 73%, so 3/4, include it in their strategic plans, and almost 90% prioritize recovery housing funding. The other 2% plan to do it in the future. Half of the states have a formal recovery house definition, and 35%, so 1/3-ish, have written it into legislation. Related to recovery housing engagement, it looks like single state agencies are engaged 92% of the times in state, half the time the corrections agencies are, 1/3 of the time the Medicaid offices are, and 1/4 of the time the court systems are. So about 80% rank it as a top priority among 9 SUD services. and 60% reported quality contingencies for recovery house funding, a 35% increase since 2020. State incentives for recovery housing development. Well, we have a lot of state incentives here, so we are fortunate. But direct funding to establish recovery housing, state opioid response funding for outreach coordinators to expand Oxford houses, interest-free microloans for recovery housing development, community engagement staff for outreach, data collection and needs assessment is a little bit lower, with 50% of states collecting outcomes data and 70% track demographics. 40% conducted a needs assessment and 40% provide incentives or financial support. So the key takeaways for us is that, most agencies, they actively look at recovery housing as a part of their initiatives. There is limited Medicaid involvement in recovery housing. All think it's integral part of their service, with 75% including it in their plans. 90% prioritizing funding, but are uncertain about future support. Among 28 states, recovery housing funding exceed $120 million from block grants. And the top service expansion priority, 80% marked recovery housing as a top priority for expansion. Let's see, I've got a couple of questions. Oh, okay. So thanks, Jean. So I looked at the paper for the economic calculator. It lists success as being a percent of each cohort that achieves long-term recovery. It is a measure given by the operators. All right, advancing recovery, the need for rigorous research. So why evaluation matters, right? So this is kind of some closing thoughts. Nothing gets funded without proof. And this push for, when you look at government grants or applications, they're all wanting you to list evidence-based practices. So a lot of our work is focused on providing the evidence for our practices. And so we have partnerships to look at gaps in evaluation tools. And we are working with recovery housing on developing practices in collecting data that helps them be successful and advance and show proof of concept. The other thing that we are working on is an alliance measure, or have worked on it, is an alliance measure. And the goal of the alliance measure focuses on the strength of the relationship between the therapist and the patient. And there's no validated measure for recovery housing until now. And so it's something that you can use to understand how successful your staff is at developing those relationships to help people move along in their recovery. Some of the components, the folks are responding to items like, I can trust other residents in the program, I can trust staff in the program. For those of you familiar with trauma-informed work, these are all important factors in trauma-informed work. I feel others in the program are working to help me. I feel I am working together with others in my program on my recovery. I feel my recovery goals are supported. I feel there is agreement on my recovery goals. There's agreement on the steps I need to take to achieve those recovery goals. I feel I can count on others in the program. I appreciate others in the program. I am gaining new ways to look at my problems. I feel hopeful and I feel safe. All those things we want our residents to feel. This is a measure that asks them if we're doing a good job at that. The other tool is the recovery housing satisfaction measure. And the reason we're all doing this, and we work with a lot of people on measurement. We actually have a paper on measurement. We have small, medium, and large data sets for how much of a measurement geek you want to be. But our goal really is that we want to tailor whatever it is we're doing to the unique program and unique community. Because what we've learned is that one size doesn't fit all, especially when you're trying to bridge community assets and leverage what exists and fill gaps. It's really about building your own and bringing people together to find something that works for them. And when we do that, when we engage in alliance with our clients and our community towards solving a problem, we get better outcomes. And so that's been our focus. And so with that, I can open it up to questions. We've got about 10 minutes left. Arnell, go ahead.
Hi. So first of all, I'm totally sold. Really impressive. I geek out on this stuff. So HomieCore, we launched full-time operations last July when we got a grant from reentry program grant from Commerce. This year we want to, go a little bit crazy and buy a place and open it up as a recovery residence, and then provide our, our services program around it. We're pretty far along. We also got a in-kind grant through Commerce for technical assistance with a affordable housing consultancy, and so we're at the point where we're gonna, go after grants and stuff. Yeah, but there's holes. I don't know what I don't know, so definitely want to engage with you guys and see, yeah, because a lot of the data we can use, but also we've got to get a what do you call it? The earnest money to buy this place, to get site control and all that kind of stuff.
All right, sorry, don't use that. I put in my Fletcher Group email with my Gmail, with the ending of Gmail. It's actually f.fletchergroup.com. Yeah, message me and we can schedule. I saw some folks had some like one-off questions. I'm happy to schedule, email, chat with you further about where you are and what you need. But yeah, so that's my email in the chat. And just know that I'm out of the office early next week for 3 days and then late the following week for 3 days. So scheduling in the, in the near future may be a little quirky, but we'll get something scheduled.
Okay, and I'll send you a bunch of like a pitch deck and all that kind of stuff. Thanks.
Cool. I love that you have a pitch deck.
Yeah.
That's fantastic. That's half the battle. Any other questions, or does anyone else want to share where they are or get a quick answer to something you've been pondering?
Well, I have a question about some of the materials you showed at the very top of the presentation, particularly the video that opens with like discussion about how substance use has been criminalized and stigmatized, and we're going to move past that. It's a very medical model video. Have you had difficulty in rural areas with that being at odds with basically the general population's conservative tendencies? Like, I wondered about, especially in the drug court context, because you said you'd worked with drug courts, like they're embedded in the criminal justice system, so they're really not in a good position to say like, well, we should dispense with the criminal model on this. They're usually predicated on it. Do you have a version of the video that instead is like, whatever the cause, we all have a goal of helping these folks get back into productive membership in society, and it's better for everyone. You see what I mean?
Yeah, we don't yet, but here's the deal. With all the guidelines coming down from HRSA on communications, I imagine that video, especially that part of the video, will have to be edited with the new administration's guidelines. So we don't now, but we can always clip it out. The SBIRT model, I don't know if you're familiar with SBIRT, screening, brief intervention, and referral treatment. it's a best practice in health care, primary care, but not widely practiced because doctors don't feel comfortable talking about substance use half the time because they have a problem themselves. No, I'm teasing. I've done the audit and the DAS with providers, and they're all like, does it count if it was like a birthday party or like a special occasion? But no, people feel uncomfortable with the conversation, right? I mean, oftentimes because if you have the conversation in the wrong way, people respond in the wrong way, and then you're like, okay, I'm just not going to do that anymore. But that screening, brief intervention, referral treatment model also kind of looks at it as like, it's basically saying the community has labeled this as a social problem, like as a moral problem. And we treat morality by putting people in jail. Like you are immoral, you should go to jail. So I don't know how else we would frame that message if we framed it. I would not choose to show that video to engage my criminal legal partners in a conversation, to your point.
Well, I think it's fascinating because it's actually remarkably similar to Lewis County Drug Court's model, except for that preface at the beginning, right? Because it is the case, by the way, Lewis County is very conservative, more conservative than most places. Nevertheless, the drug court enjoys widespread popularity. And I think it's because it's not about an abdication of responsibility. It's about building from a low point to a high point. And it's still a diversion model. So you can still say diversion. You can say this is a crime, this is a problem. The question is how to get people out of it, how to solve the problem. And here's the model about how to solve it. So it seems like you would almost be able to use the same exact message and just talk about it as being something that we label as a crime, but what's the best way to move out of it?
Yeah, no, I appreciate that feedback. And I know we are in the process of making edits to things with our new communication guidelines. So I will pass that along. We have just 3 minutes left. Are there any other questions before we conclude today?
I just want to say thank you. So much information, amazing presentation. And once we're currently looking for a single family home in a HUD area. We're in Thurston County, so we'll be able to, I'm sure, find one soon.
Yeah, well, reach out. Remember, we've got all these tools, webinars, like you can tell me what you need and I can say, here's something that I think is helpful. You can do on your own.
Awesome.
Whatever it is. Don't.
All right. I will reach out for sure.
Yeah.
Yeah,
Well,
because
it's nice to meet everybody and everyone. My colleague Jean is on here. Jean, will you wave real quick? We're going to be doing some like data work with Walker operators, certified operators. If there's any of you on here, Jean is my colleague. Meet her too. We'll talk on a different day.
Yeah. Thank you so much, Milena. Yes, so I will get the slides. This video is recorded, and we will, and like probably towards the end of the week, get it sent out to all the emails that you registered with, so that you have it as a resource and you can click on those links and visit, look at those studies. But yes, oh my gosh, wonderful information. Okay, everyone have a great day. Reach out. I'm going to put my email in the chat too.
Take care.